Welcome to Smoke and Mirrors, the podcast that cuts through the noise of the many policies and regulations that affect American agriculture. Each week, we pull back the curtain on the programs, policies, and perceptions shaping the agricultural community in rural America. If you've ever felt like something doesn't add up, you're not alone. I'm Jenny, and this is Smoke and Mirrors. Let's make sense of the maze we call farm policy.
Welcome to Smoke and Mirrors, the podcast where we make sense of agricultural policy. I'm Jenny Ift. I teach agricultural policy at Kansas State University. I'm excited to have Alex Hollingsworth with me today. He's an associate professor who studies health economics at The Ohio State University. Alex, thanks for joining us. Want to tell us a little bit about yourself?
Yeah, sure. Thank you so much, Jenny. I'm really excited to be here. I cringed there when you said The Ohio State. That's the one thing I'm like, oh man, I wish we could delete that. It's
Trying
like
to follow the rules.
I know everyone here, they love it that you do it, but I'm like, oh no, just say Ohio State. And I'm like a big OSU football fan too, so it's still
I used to watch last year.
Ooh, there you go.
Don't you remember? Are you that big of a fan?
What, OSU?
Yeah.
Yeah, I'm a huge fan.
Okay, all the K-State fans were watching last year.
Oh, yeah, because Will Howard.
Yes,
Okay, sorry.
Yes.
That's why last year I was like, why were you watching last
year? I was super tuned in last year.
I was willing to take all of the credit for Will Howard and not recognize where he came from. Yeah, he was amazing. He just showed up and was like, let me be really good. He played one game with like a concussion the entire game. Like,
I believe it.
Yeah. So, yeah, no, it's exciting to be here. I love the vibe of your podcast, the idea of like just connecting sort of without the jargon. So I'm just really excited to share anything with your listeners about health.
And I've been exploring health-related topics on this podcast since it started. I think I'm on my 20th episode or something now. But with the Make America Healthy Again movement, I think focus on public health is bigger than ever. And I think there's a lot of areas, not all areas, but a lot of areas with consensus. And so for my listeners, I think just understanding what is public health, what we know works, what we know doesn't work, kind of just having that baseline understanding is important as we continue to have these conversations. But I guess let's start out. What is health? How do we think about health? What does that mean?
Yeah, I mean, it's sort of a complicated question to unpack right there. So I used to teach this class at Indiana University that was like an overview of the U.S. healthcare system. And we'd spend like weeks on this exact question that you just asked. Like, what is health? How do you define it? What matters for health? And one of the things that I just want to have in the forefront of people's mind is health does not necessarily equal health care. But a lot of what we'll probably spend a lot of today talking about is health care and how complicated and expensive it is. And so you can just sort of think of health as not necessarily the complete absence of disease or the complete, like, it's not like you're like a Greek statue of like perfection, but just the idea that like with whatever set you have, that you're sort of in an ongoing okay state. I realize this is like, I'm trying to cut through the jargon.
That's highly technical.
It's very technical. Yeah, you're in an okay state, right? So sorry to hear Oklahoma State fans out there. But, if you're...
Ooh, they're having a rough year.
But, in any event, this is going to quickly turn into a college football podcast if we're not careful. But
I don't think the crossover would last very long.
That's right. Yeah, I can just talk deep cuts into Ohio State roster decisions. But in any event, trying to figure out what matters for health, for basically just at a population level, at an individual level, I think is a good exercise before we get into thinking about like, what do we spend most of our money on? Because it's not going to be surprising. And this is where when you like reference the MAHA movement and other people, like it's stuff that's like food is really important for health. Yeah. Having an environment free of exposure to pollutants, not dying of a preventable disease when you're 1 year old. Like These sound like very simple things, having access to clean water. These things matter a lot more for long run health than having access to like a really special proton beam that like eliminates a form of cancer in your kidneys when you're 72. Like that might be awesome. And you might want that if you have that rare kidney cancer. But like, if you're just talking about like, what should we do to improve infant mortality? It might be like, give everybody food and make sure they're not breathing in coal smoke.
So you said infant mortality.
Yeah.
You want to unpackage that a little bit?
Yeah. So like an ideal way to measure health would be some like highly personalized way for each person. And then you'd aggregate it up in some way that like we could be like, Jenny is 80% health, Alex is 100%, whatever. But these ideas, as any of us who collect data on our own, realize they're easier to say than they are to do and collect and sort of compare across time. So a thing that we sort of care on its own about, but also because it's a good measure of underlying human population health is infant mortality. And another thing that's sort of similar is like life expectancy. And what infant mortality is it's basically among babies that are born, live births, how many of them die within the first year of life. And so it's a very crude measure. It's a seemingly simple to collect and keep track of across time. There's, of course, nuances, but it's something that allows us to compare, like, even within the United States, you can look at within the same city, the Black infant mortality rate compared to the white infant mortality rate. You could look at like the rural population versus the urban population in a state. You could compare it across time. And then it gets a little bit tricky with like, well, in the United States, for example, Emily Oster has a cool paper on this. Like, what if more babies are born in the US who would otherwise have been stillbirths or miscarriages that in other countries? So there's like some differences, like, as medical technology and things changes across time. But overall, it's sort of a pretty good proxy for population health.
I remember reading somewhere that, let's say 200 years ago, that, I don't know, maybe 100 years ago, I don't know, infant mortality was high everywhere. But if you could get through those first few years, you could live a pretty long life.
Yeah, that's a perfect thing that actually is one of the first graphs that I would teach in this class. And so Sean Nicholson at Cornell, he calls this an underappreciated moonshot. It's one of my favorite phrases. And this is like the change in infant mortality across time here. And so it used to be the case that like, the data are a little bit sketchy. So this is a rough approximation, but something like 30% of babies would die within the first year of life. And now it's much smaller. It's something closer to 1%, which is still a lot, but it's much smaller. And then what you brought up there is this idea about conditional life expectancy. So if you could just like make it through the very dangerous years of being a child, your conditional life expectancy was pretty high. So England, Scotland, and Wales, they kept data on this conditional life expectancy, all the way back into the 1700s. And you can see, and I might, we could find the exact figure, but roughly, like if you could just make it to like age 10, then your not expected age of death, but sort of the average life expectancy was close to 60 years old. And so, we've been making improvements even on conditional life expectancy, but the majority of our life expectancy gains, you hear like, oh, people live 40 years longer now just because people aren't dying as children as frequently.
Yeah, and I read a book about how different cultures treat babies.
Interesting.
Maybe anthropology,
yeah.
but there's this idea in some places you don't become attached to the baby, or you like almost don't see them as a full family member until they get past a certain age, and how that had kind of happened because of this high infant mortality, which makes sense at some level.
Exactly, right? If there's like some huge probability, I'd never thought about that before, but of course you're right. Like norms and things would develop. Like family size is a function of expected number of children that live to be a long time. We're venturing pretty quickly outside of my area of research, but like a thing that I hear but like a thing that I hear frequently is like, you could view children as insurance. And so if you need, like, let's say you're working on a farm and you need 4 or 5 laborers, and, it's not necessarily that everyone's in there doing some Bellman equation and first order conditions, but like, if it's in expectation, some number of kids die, you'll have more babies. And then as infant mortality rate declines, people have fewer children.
Absolutely. And now we worry about too few children in some places.
Yeah, exactly.
Yep.
Yeah. I mean, and then like the policies, like, how do you address this? How do you like encourage fertility? Like, this is again, like I don't know anything about how that actually works, but it's fascinating and important public policy question.
Okay. So we talked about what do we mean by health, what matters, and key measure is infant mortality. It's also having sufficient food. You talked about pollution, not dying of preventable diseases. Is that how we're thinking about that?
Yeah, I mean, and then there's lots of things that are correlated with this, some in a tight causal way. I mean, like even today, sort of we sort of the beginning of the anchoring our conversation was sort of like thinking back 200 years ago. But like even today, Raj Chetty has like great work that came out in JAMA in 2016 that just looks at a sort of estimated life expectancy, but like pretty good estimates that are simply based off of income. And you can see like 15-year average life expectancy difference, even within like the same county, just based off of wealth. And so things that are related to education, to wealth, to genetics, all of these things matter for health as well. And of course, it's kind of a difficult causal nut to crack. Like if you're richer, maybe you buy, like I'm running an air filter, right? Like a thing in my office right now. So if you're like in a high income area, maybe you can like adaptively minimize exposure to certain things. But still, the idea that all these things contribute to health
is
something that we shouldn't ignore.
Let me make sure I understood that. So what they show is that there's a 15-year life expectancy gap based on your wealth, the wealth of your parents in the US.
So Chetty has a bunch of work that does intergenerational linkages. So like the wealth of your parents compared to like your own wealth. I think in their JAMA paper, it's just like your own wealth. It's not the linked to your parents' wealth one, but like it's a fair guess that they probably have some paper that does the linked thing as well, because they have so many things on this. And essentially what they do is they have this like really rich data on IRS tax records, and they can go through and like look at, here is the within a given area, here's our expected age of death based off of the income of the household.
So income is strongly correlated to health outcomes, but there's a lot of potential channels that could be operating
right?
through.
Like maybe I live in a really fancy neighborhood that has lots of trees. Like all my examples will end up being pollution, even though more things affect health than just pollution. And so if I have like big fancy trees and the neighborhood property values are high, maybe the trees help filter the particulate matter. Maybe the trees help, conditional on a heat shock. I'm a little more insulated from this. So there's all sorts of things that are tied up with that. Social services, what's the level of crime in my neighborhood? All these things are related to one another. And this is not to say that healthcare does not matter. It's just all these things matter in addition to healthcare. And many of these things I'm talking about, like I say this phrase all the time, and there's no way you could actually test this, but like if you could give me from a population health standpoint the Clean Air Act or the concept of health insurance, I'm not so sure which one would be more cost effective. It might be the Clean Air Act, like because it just improve. You don't need to do anything other than exist. You just get to breathe cleaner air now. Whereas with health insurance, like there's multiple mitigating things that need to happen before the health insurance can help.
Are there numbers from that? Like how many lives the Clean Air Act saved or something to that effect?
I mean, there are, and like I should have them right off the top of my head, but I don't. So I've done like some work that's like, what's the like health benefits of the Clean Air Act? Lots of other people have done work there too. And like, it's big, right? The welfare benefits are quite large.
Okay.
So I'll find them and we can put them in the show notes. It is like, the Clean Air Act is many bundles of lots of different legislations that sort of changed across time. But like, if you just want to think about it simply as like, we are going to try to minimize air pollution out there with some cost consideration, that broadly defined really improves pollution and really improves population.
So yeah, I'm thinking you have nutrition, you have your social environment, which I think could be safety, but also I think family ties, community 100%. Ties are important. You have access to healthcare. Those things are all important, but I think we haven't totally figured out how much each one is or what the combination is, or do people have a pretty good idea of that?
Well, it's tough. It's tough to think through, right? And so there's like a figure I can put up in my class that's like food for thought. But of course, like you're not going to get some it's not like 9.8 meters per second squared. There's not some like true constants that's the same for everybody. And so David Cutler has this cool book called Your Money or Your Life. And one of the key things that Cutler sort of talks about in there is, I don't think he's too dogmatic with this exact year, but it's basically like health care, like medicine, didn't like noticeably start changing health outcomes at like a population level until like around the 1950s. And so there's like really good work by one of my co-authors, Melissa Thomason, that shows that like antibiotics, the way that you and I would think about them in like regular person speak today, basically didn't exist until 1937. And so like pre-1937, like you couldn't have the benefit of antibiotics. Like it just wasn't there to have a benefit.
I'm pulling random facts from my head. You can fact check me.
Great. That's we got a podcast.
That's why we do this.
But yeah,
the sort of better sanitation was it? I don't know if it was 100 had a way bigger impact than the medical community or the
100%.
Okay,
yeah, exactly. So like Claudia Golden's got work here. Other people have work in this area. That's basically like, so if you want to like divide U.S. history, and you could do this for like any other country too, into sort of like three eras, you could think of like with respect to improvements in life expectancy or infant mortality or health. You could think of like 1750 to 1850 as sort of being this period where there was like lots of improvement in economic security. Like we could like get more food, there was some sort of sanitation stuff happening there. And then roughly 1850 to 1950 is like, it's when we were like doing massive public work projects, getting sewer systems in, getting clean water. In Chicago, they very famously reversed the flow of the river because it used to be the case that like where the stockyards were was essentially where people were getting their drinking water. They're like, that's yucky. And so they did a complicated thing. And if you're a person from St. Louis, you probably really didn't like it because then they reversed the flow such that the bad stuff was going towards St. Louis then. But that like really improved mortality. It really improved waterborne diseases. And that mattered, like, that all affected health in this really high sort of marginal value of public funds sense.
But also just understanding of germs. So doctors started cleaning their hands and cleaning equipment, yes. and that was huge as well.
Yeah, and I should look all this up ahead of time, but like Lauren Hone Velasco has this cool paper. I saw it like in a working paper form, so maybe it's slightly pitched differently now. That was basically like, took a while for germ theory, like when we learned about germs, to sort of disseminate to regular folk. But like, what about doctors' kids? And so they use like linked census data to show like differential health effects for the family members of doctors who like ostensibly could learn about germs earlier than like a lawyer's kids. I think that's the control group they were using in the working paper. But that stuff, like, we didn't even like think about germs until like the late 1800s. Like, I don't know the exact year when he was doing this, but like Lister from Listerine was sort of like an antiseptic that we had access to. But basically, like, you would die from having a surgery in 1910 because like maybe we could like remove the tumor, but then you would die from an infection. So it wasn't until like 1937 that like surgery could be like a safe thing.
This was not that long ago, especially
I know,
on the scale
right?
of
It seems
human
like a
history.
long time. Yeah, the scale of human history, we're like, that's like a blip.
Right. What about nutrition? Obviously important, but there has to be a lot of subtleties in there.
Oh yeah, this stuff matters so much. And then like the way you want to think about nutrition. So like one of them is just like, how many calories can I get per dollar, so to say, right? Just like how easy is it to sort of extract nutrition from, I don't know, a particular crop or particular acre, however you want to sort of frame it. But then another one is even conditional on having the agricultural, setup. Like, is it safe? Is there food storage? How do you get things from one place to another? And this is like, again, we'll pretty quickly go outside of my area of expertise here, but like Paul Rohde has this cool paper that basically begins with like a phrase that's something along the lines of 1917, milk could kill you. And that's because cows had bovine tuberculosis. And it wasn't until we developed a skin test for cows for tuberculosis that we kind of knew which cows we should, cull and which cows we should be like, all right, you're fine, go over here, we can get milk from you. And so that had a big sort of nutrition shock. And we were learning these things throughout time, and also agricultural practices, and the U.S. was getting richer. All of that was sort of happening at the same time to just improve access to sort of, low cost calories per dollar, but also like a safer nutritional, like, food environment.
Obviously, like not being hungry, having regular food, big improvement. And then there's quality of food. And what does that relationship look like? When do you see the most gains between nutrition and health? Where we worry about the type of fat we're using and very marginal things sometimes.
This is enough outside of my knowledge base where I'm kind of hesitant to like give a thought there. But I do think that like anything in this area, there's going to be like, you can make a graph where the y-axis is like benefit and the x-axis is like cost. And it's going to be one of these diminishing returns thing. And I think the first sort of important thing is, are you getting enough calories? And then it's like, do you have enough nutrients? And then it's like, okay, are there PFAS? Are there like other contaminants and things in there? And of course, you don't want contaminants in there in a costless world. You'd want to hyper optimize everything. But sort of at baseline, it's just like, let's just get enough calories out there. And so I think we're definitely in the portion of the distribution where there's, it might be bending sort of the other way in terms of nutrition. Like, we are getting too much nutrition. There's like room for too many calories, I should say. There's like room for Ozempic to sort of like shift us back the other way. But, I don't think I'm not in really a knowledgeable place to be like, oh, you should have this much saturated fat and this few vitamin A or whatever.
Yeah. What are the gains to improve nutrition?
Yeah. There's like good papers. Like there's there's like the free and reduced price lunch program. And then there's these cool research designs that are like something along the lines of, there's like these cool research designs that look at something like, well, once like X share of people in a community or at a school become eligible, then everybody in the school becomes eligible, and then free breakfast is offered. And then you can see like major changes in test scores. And, again, this is like not necessarily telling us about like the marginal value of a single calorie, but like, some of these kids might not have been eating at home, or they might have been getting like a crummy meal. And now all of a sudden they're doing 0.1 standard deviations better on test scores because they ate some breakfast. Like, that's amazing. And so that's not exactly your question about health. It's, these studies are always so wild to me because they keep showing the same effects. Like, kids do better in school when they when they're not hungry.
Absolutely. Absolutely. One thing I would, we talked about, I don't know if overnutrition is the official term.
Yeah.
But
yeah, I don't know. I call it I eat too much.
Yeah.
I'm with you.
Exactly.
Yeah.
But when I talk about, I teach an agricultural policy class. We have one lecture on food policy because I can't do the whole course, but I want people to know about it. And you go through the types of food insecurity. You say this doesn't always relate to somebody being underweight. They could be overweight because maybe the quality of their diet is affected. Maybe when they can eat, they're going to eat more, and just try to help them understand that. But that seems pretty complicated.
Yeah, no, I'm always like, I feel like I speak out of both sides of my mouth about this. Whereas like sometimes I'm like, boy, I just want people to have high quality food. It seems appealing to me to have like fewer processed foods and whatever. And then out of the other side of my mouth, I'm like, does all that matter? Like what matters? Like I really like Emily Oster's book, Expecting Better. And like I try to think about like, how would I consider like the idea that like oat milk is actually good for you or better for you than dairy, I find like unlikely. But I don't know. That's just like, that's a vibe, rather than anything else. So I think both things. Yeah.
Which one is more highly ultra processed, which we don't need to go into that.
That's exactly where I go. I'm like, their advertising campaign was like milk for humans or something. I was like, huh? I don't know.
That's funny. All right. Do you want to switch gears to the health? What is our health system in the U.S.? How is healthcare delivered?
That's the one. Well, that's one where I used to teach this class to like a bunch of 18-year-olds. And I was like, listen, I know you're doing whatever it is on your computer, but like, believe me, in 10 years, you'll care about health insurance. I'm happy to do that. So a lot of like what we care about in the US and what a lot of the policy is about is sort of until recently, until kind of like this MAHA movement, isn't about like, hey, we need to focus on health, but it's kind of we need to focus on health financing. Because it's like it's very salient, right? You pay this big health insurance premium, you think you have insurance, then you go to the doctor, and you have some like huge deductible you still owe. It's confusing for people. People don't really understand it very well. And so it's what a lot of the topics of conversation, right? It's a huge share of the federal and state budgets. I mean, it's a legitimate issue. And so I think it's sort of, we just established there that like health is determined by many things, not just healthcare. And so I think it's we should just talk about what is health insurance. All health insurance is it's a financial instrument that allows you to access health care in the event that you need it. And there's some forms of healthcare maybe we think you should get every year. Maybe you should go see your doctor every year or something. But there's some forms of healthcare you don't hopefully ever need. And if you do need, it's very low probability that one particular person needs it. Something like chemotherapy for a rare cancer. And the way I teach this in my class is I first talk about the Powerball gambling, where I'm like, hey, like, what are the odds that you win the Powerball in a given, run? Let's say you go buy a ticket. It's something like the same odds as if I've randomly selected a person from the U.S. population. I select you. It's like 1 in 300 million. But, if you win the Powerball, you get, like $1 billion. It's amazing. You should think of health insurance as sort of, rather than I pay money to play the Powerball gamble, I pay money in terms of a health insurance premium to avoid playing the evil Powerball, which is at some
Evil
random
Powerball.
chance I get drawn from the population, and then you owe some large amount of money. Now, of course, it's not going to be $1 billion that you owe, and the chance that you lose isn't 1 in 300 million. It's more like, hey, if you get cancer, it's maybe a 10% chance, something around that odds, and it'd be like a couple $100,000 you'd owe. That might be something you could never self-insure against. You could never survive sort of losing the evil Powerball without some financial protection against that. And so the promise of sort of group insurance is basically everybody pays in actuarially fair premiums, which is sort of like the probability of the bad event times the cost of the bad event for everybody into a big pool. And then we together can sort of survive, so to speak. We can pay for very expensive events that are really low probability.
Well, isn't it? There's a part of health insurance that is, yes. So if you get cancer, it doesn't bankrupt you and your family for multiple generations, or something. Or you can't be treated because it's so expensive, I think. So there's that side of it, these sort of catastrophic events. But it's also a sort of a payment plan for routine healthcare. How would you characterize that? Because it seems like, are those two different things, or should we think about them?
They're totally interconnected. I typically teach them as two separate things, where I first am like, let's just ignore any value of healthcare. Let's just assume like it is like the evil Powerball. There's nothing other than you owe money. And then you're like, oh, it's a financial instrument in some respects. But the other thing that you bring up here, which is very appropriate, is that, hey, health insurance might actually increase your access to healthcare. And so you used the phrase payment plan, but I'll even make it simpler. It could be the case that like a doctor in your community won't see you unless you have health insurance. And so like it might be the case that you need health insurance in order to go to the doctor. And then there's different plans and things that like we do view some things, we think there's some value, some return on investment from like preventative care. So you might be like, hey, you know what? I don't want to dissuade you from getting a flu shot. So we'll just make flu shots free. I don't want to dissuade you from getting like a mammogram or a colonoscopy or seeing your primary care provider. So we'll like bundle those into things that sort of are like, I say free, but included in your premium that you pay. You pay no extra to sort of see this because it might have some return on investment.
I was trying to say payment plan to capture that we are paying for these preventative services.
And then like a whole separate thing, which is just like insane, is also, let's say that like there's a Jenny and a Jenny clone, and both of you are like, billionaires. You have tons of money. So you could feasibly self-insure. You could pay for like anything that you wanted to. You still might want to have health insurance, even if you could self-insure, because the prices you face when you have insurance are different than the prices you face without insurance, because all the prices in healthcare are negotiated, meaning that like if you're a member of a big group, you'll face lower prices. And since it's not typically the case that you can see these prices, it's sort of like an expected price menu. And you'd be like, well, if I'm a member of a big group, I'll probably pay less. And so it still might be worth it to have health insurance, even if you're paying full freight, so to speak, because if you and I see the same doctor, or your clone sees the same doctor, you would pay a different amount.
How do you think about market power in terms of health insurance in hospitals and clinics?
I mean, it's so complicated. That's why all these like fancy IO guys have these like crazy papers and like Restud and Econometrica, because like it's a multi-sided bargaining thing, right? You get like hospitals, you get doctors, you have patients, you have employers. They all have a degree of market power, but like the markets they're operating in are different. And so everything comes through this complicated sort of, it bubbles up through this crazy system that we have. And we haven't even touched on the idea. We just talked about health insurance as like a concept. We didn't even talk about the idea that like we don't have a single health insurance provider in the United States. We have like thousands of health insurance providers in the US. And it makes it really complicated to think through like let's say you're a random farm laborer or a random farm owner or a CEO of a large company, that is related to the agriculture sector. They might all live in the same city and have completely different health insurers and have different networks of physicians that accept them because of this differential bargaining power.
And I hear a lot about, I remember my parent, I hope I could say this, they were pretty excited to get on Medicare because they're self-employed, they're farmers, and it had gotten really expensive just for the catastrophic insurance. And then you're old enough, you can switch to Medicare, and all of a sudden a lot of stuff opens up.
And I think if it's okay, can I explain what Medicare is?
Please.
If people don't
know.
Okay. So basically in the United States, there are typically 4 ways that people get their health insurance. There's employer-sponsored health insurance. About 50% of people in the U.S. get health insurance either from their employer or from a parent or a spouse's employer, but somehow from a job, which is a weird thing we could talk about on its own. About 30% of Americans get health insurance from the government, sort of broadly defined. This might be Medicare, Medicaid, or TRICARE. And then sort of the remainder either are uninsured or they direct purchase health insurance from a provider. And how many have direct purchased has changed with the Affordable Care Act and the existence of marketplaces. I'll step back one thing though to say like, well, what's Medicare, what's Medicaid, what's TRICARE? What are those government sources? So Medicaid, you aid the poor, is health insurance for low-income individuals in the United States. And Medicaid's really complicated because every state operates a different Medicaid program. So there's really 51 programs. Each state has sort of a partnership with the federal government and how they run it. Medicare is a little simpler. I mean, it's still crazy complicated, but it's a little simpler because it's one federal. There's one set of Medicare eligibility for everyone in the United States. And essentially it's, are you disabled or do you have end-stage renal disease or that's kidney disease, or are you 65 and above? And so that's what you're referring to with your parents. Basically, that's essentially universal health insurance for elderly people in the United States. And we like to talk about, one of my favorite one of my favorite images that I show in a class where we talk about politics in healthcare is a person holding up a sign that says, "Get your government hands off my Medicare." I'm like, well, that is actually a government universal health insurance program for elderly people. And so like we have fundamental misunderstandings, I think, in the US about like what these are and how much they cost. Sorry, that was a lot of detailed stuff randomly. So sorry if that took us off topic.
I was planning on asking you what, the share of what types of insurance or how many people are uninsured today, approximately, do you know? It's less than 20%, so.
Yeah, I would say it's about 30 million, but like that is just a guess right now from, I haven't taught this class in a couple years. And so I used to like every year update the slides, but I'd say it's somewhere around, 10-ish%.
Okay, about 10%. But the one place you can always go is the ER. Is that true?
Yeah, basically there are laws that sort of make it such that you cannot be turned away from the emergency department for not having insurance. There are not laws that say they can't charge you money though. And so, it's often a very expensive choice to make. And so I'm not encouraging anyone to not go seek medical care if they're sick and need to go to the emergency department. But it's definitely true that if I went to the emergency department and didn't have insurance, and I went to a doctor who would see me and didn't have insurance and got the exact same procedure done, the bill might have like extra zeros at the end of it from the emergency department because it's way more expensive to get care at a hospital. And so like this is like a big point that people often talk about when we think about like healthcare policy is we don't have a system in the US where we have universal insurance, but we, in sort of a backdoor way, have a system of universal coverage where people can go get access, but it's not necessarily allocating people to where it's like the most cost effective. Because implicit there's the doctor can turn you away, but the emergency department can't. So I forgot that key little bit.
Okay. And so you could incur debt. I mean, people might never pay it, but that
For sure.
debt would stick with you.
And this absolutely happens. And then like what's super annoying, and you talked about like bargaining power and market power and whatever earlier, is like I might have awesome health insurance and maybe I have some elective procedure and I'm like, I'm going to go get this elective procedure done at XYZ hospital. And I check and that hospital is like covered by my insurance. And then I show up and like the team of physicians that day might be a different team than normal. And maybe they're not covered by my insurance. And so it's effectively like I didn't have insurance. And then you could get a bill for like $35,000 or $80,000. And there's like a whole NPR series where like every week for a while, they were like looking into these surprise billing is what they called their series. And I would share it with the class and we'd be like, see, imagine this is you, right? So like I have an insurance policy that has out of network cap for that exact reason, because I'm like too afraid.
Absolutely. Well, I mean, yeah, it's one of the nice things about being employed by a university is the insurance has real bargaining power with.
Yes.
Yeah.
In agricultural workers, like I looked this up ahead of time. There's these a couple AJE papers that have looked at this, but then there's also the National Agricultural Workers Survey. I guess it's easier for me to say this. Those who operate family farms don't have terribly different insurance coverage shares than the ones that I shared for the U.S. population. Something that I learned in preparing for this, though, is one of the ERS has this one survey, farms. And they, in 2015, did a survey of family farms and asked about family farm insurance rates specifically. And so everything on average matches the rates that I just said. But I did see that 41% of those on dairy farms had no insurance. And so about roughly among family farms, 11% of people don't have insurance. But, there's a huge heterogeneity there. There's a lot of difference there across family farm type. And 41% on dairy farms had no insurance, but only 5% on grain, oilseed, tobacco, or cotton farms had no insurance. And so, I don't know enough about agricultural to understand why 41% of dairy farms would lack insurance.
There's a lot of small dairies still. I mean, it's consolidating like everything else, but it could be that these are small dairies where their finances are pretty tight.
Yeah, I just found it fascinating.
I will tell you. So I grew up in Illinois on a farm, corn and beans and hogs. And the people that had dairies were considered the most hardcore. You got to milk the cows 2-3 times a day. They didn't go on vacation. So it doesn't really surprise me.
That they would continue operating, right? Even if no insurance. Yeah. Well, anyway, when I think about implications for different industries, at first I was like, oh, cool. I found some statistics that say farmers are sort of similar in where they get their insurance from the rest of the US, but I found that. Then I found a couple of other interesting things. I was really interested in the survey, basically in the statistic from ARMS that said that among family farms, that 55% still had employer-sponsored health insurance. So I tried to dig into that a little bit.
That's because yeah.
Well, a lot of it comes from off-farm employment. Basically, a spouse has health insurance from another job. And so it sort of masks, it seems like, oh, well, they might be purchasing it for themselves, but it's coming from another job source.
So you have to be careful when you look at statistics based on the number of farms in the U.S. because you are a farm if you have the capacity to produce, in a typical year, produce $1,000 worth of agricultural commodities.
I didn't
Today,
realize. Okay, interesting. Yeah.
one calf is worth more than $1,000.
So you're a farmer if you just have one cow.
Yeah, absolutely. It's
interesting.
And half of all farms, they lose money on their farm operation. So they are dependent on off-farm work. So again, if you're looking at all the farms, it doesn't surprise me that it would mirror the U.S. population.
Fascinating.
I have heard a lot of stories, and it's not my main area, of farm families where they don't have this off-farm work, that getting insurance is for, what would you call it, self-employed. I don't know what the term is, but yeah, as a small business, getting insurance as a business without bargaining powers can be painful. I think Farm Bureau and some other groups have helped with that.
Yeah, I mean, and it's typically, pre the Affordable Care Act, also known as Obamacare, it was really hard to get health insurance. Yeah. If you were like a single individual, like if you wanted to direct purchase insurance, like not in a group and just be like, hey, like United Healthcare, may I please buy an insurance plan? Yeah. They would scrutinize your medical records and they would either charge you a fair premium. Like, so if you were a sick person, they'd be like, all right, pay me a ton of money per month. They might deny you coverage, or they might put riders or exclusions or something on the types of things you were most likely to need healthcare for. And so the Affordable Care Act, one of the things that changed with sort of this 2014 legislation was that it made it basically insurance companies couldn't deny you coverage based off pre-existing conditions. They couldn't charge you higher premiums than people outside of limited age bands based off pre-existing conditions. But then that makes it more expensive for everybody else. Like, I know it's called the Affordable Care Act, but that's going to change the business model for insurance companies.
Yes. Well, the names of bills is a whole nother episode.
Yeah,
oh my goodness.
Yeah. How do you creatively, like, what is the biggest limitation of this legislation? Let's frame it such that that's not a limitation.
And when I introduce the Inflation Reduction Act, I say this is not a retirement account or the Irish Republican Army. So I don't think my 18-year-olds get it, but I amuse myself. You have to.
Like, here's an IRA. I'm like, oh, yes, of course. Yeah. Let's go to Northern Ireland.
Have there been studies that have looked at the health impact of losing insurance or gaining access?
Yeah. And actually, there's unfortunately fewer studies on the first thing you talked about losing insurance, even though I think that like there are reasons to suspect that the health effects are not symmetric. So like Sebastian Teo Trio has like an interesting paper, and some other people have also studied like when Tennessee Medicaid sort of had some disenrollments, so basically kicking people off of insurance. I'll focus on more studies have been done about what happens when you gain insurance. A large number of studies that basically use the Affordable Care Act Medicaid expansions as sort of a quasi-experimental research design to study what happens when different groups gain access to health insurance. Just as like a super brief introduction to why that could be used here. A part of the Affordable Care Act required that states expand their Medicaid, so that's health insurance for low-income individuals, for those childless adults that made up to 138% of the federal poverty line. But in 2012, the Supreme Court basically said, hey, the Affordable Care Act is constitutional, it's fine, except for that part about Medicaid expansion. And so some states chose to still expand, some states didn't expand. And so there's a lot of research designs that's basically comparing like an Alex in state A that chose to expand compared to someone that's observably the same as Alex in another state that didn't. And so like one of those studies was actually a couple of those studies have been published in AJAE looking at agricultural workers. And so like one of them that was published in 2021 showed that documented, at least agricultural workers experienced a 24% increase in the likelihood of having health insurance after the Affordable Care Act Medicaid expansion coverages. And that's very different. Basically, those who work on farms have very different sources of health insurance than those who own the farms, right? So a lot of these people, they don't have employer-sponsored health insurance. The farms aren't providing it, making enough money to go buy insurance on their own. And so they're getting insurance from Medicaid.
Yeah, that makes sense. So people looked at the health impacts of gaining access to insurance?
Yeah. So then there was a paper, 2022. Sorry, that's what you asked. And I started talking about just the insurance impacts. There's a 2022 AJE that also looked at like basically these same types of workers. What happened to their use of preventative medical services? And they basically showed that like people stopped going as much to the emergency department after they gained access to health insurance. It seems like there were positive health effects. Weirdly, I guess, given how we opened up the whole conversation of the podcast, of the episode, maybe it won't be so weird. But up until kind of recently, even broadly linking mortality to having health insurance has not been as clear-cut as you might expect. So there's been really good work by Laura Weary, Sarah Miller, Jacob Golden. They all have co-authors that are on their papers as well that I'm omitting here. Basically, there's 2 papers published in the QJE, but like within the past 5 years that like very clearly document a relationship between mortality and health insurance. But like the sort of OG experiment that we did in the United States was the Rand health insurance experiment. There was also something similar done in Oregon. It was more of like a policy design that people took advantage of. But those sort of had experimental variation in who had health insurance, and they did not find statistically significant evidence of mortality effects. And so for a long time, people were sort of like, I don't know if there's a big effect or not. And it wasn't until like very well done studies by Jacob Golden and Sarah Miller. This is not just among farm workers, but this is among all Americans.
More broadly. Okay.
That show a link between health insurance and mortality.
Okay.
Even though like conceptually it makes sense why like being able to go to the doctor might matter for health. But it turns out lots of other things matter for health beyond just going to the doctor.
I would imagine. And do those, and so as economists, we do things like this that maybe aren't cool, but if you could look at it from a cost-benefit perspective, right? We have a constant statistical value of life, but did they kind of look at, in terms of public investments and these sort of quality of life or mortality measures, did they try to
so like,
some
for
of
instance, like I'm sure it's like well done in like the end part of their paper, but like Sarah Miller, it's Johnson, Miller, and Weary. So I should just make sure I say all the authors' names there. So I don't just only give credit to Sarah and Laura. But so in their paper, I'm sure they do something that is along these lines. But my prior is basically it's going to be a slam dunk ROI because it's really cheap. Medicaid is really cheap. And if you could save like one prime aged worker and you enroll a bunch of people who are like less likely to have like really expensive medical services, it's just probably going to be a really good return on investment. Whereas like investment in Medicare, on the other hand, like most of Medicare expenditures are spent on the sickest people right before they die. And you personally might want the latest, greatest, fanciest medical technology if it extends your life by 2 or 3 months. But in terms of like, as you said, sort of the gross economist, that might not have nearly as much ROI as like giving a baby a vaccine and now the baby lives for like 83 years.
Right. All right. Got it. All right. Is there anything else? I think we're probably running out of time here. Is there anything else that you wanted to discuss or that you think listeners should know?
No, I mean, I just think I'm excited that you're interested in these topics and that the idea that like health and health insurance and access to healthcare is sort of on the minds of people in the broadly defined sort of ag space. The one thing we didn't really talk about at all that like we don't need to extend is like, in addition to just like the financial access, there's a changing provider access too, particularly for those in rural communities. So like rural hospitals are closing. There's not a lot of doctors. And so the system we have in the US basically rewards, if you're a physician, you make more money. If you're a specialist, you have to be in like a big urban population center. And so we just see a declining number of doctors and hospitals. And it's driving distance wise, getting harder and harder to go to a doctor. Absolutely. And so we didn't talk about that, but it's just a thing to keep in mind for anyone like interested in research topics or something like that. Like that's an area of important policy.
Yeah, absolutely. I need to do a podcast episode on that one. But, I think as we're seeing this growing interest in agricultural production and health, I think understanding things like this, what's the healthcare system, what does health mean, are really important because it is complicated. You can't get around that. But before we wrap up here, you want to talk about your podcast a little bit?
Sure. Happy to. So I have this other podcast. It's called The Hidden Curriculum. It's co-hosted with Sebastian Teo Trio. And basically it's just about stuff. It's things that you are important for professional success that some people know, but aren't formally taught in graduate school. And so sometimes we'll do an episode that's like, how does an academic journal work? Sometimes we'll do how do referee reports work? It's sort of a hodgepodge of topics where that is the unifying theme. And so please check it out if you're interested. If you have ideas for topics,
send my grad students there.
Yeah, exactly. So it's for grad students.
Awesome. All right. Well, thank you so much for your time.
Yeah, thank you, Jenny.
All right. Take care.
Thanks for joining us on this episode of Smoke and Mirrors. If today made you think or see things a little differently, share it with someone who appreciates cutting through the noise. Don't forget to subscribe, rate, and leave a review wherever you get your podcasts. Thanks for spending part of the day with us. Until next time, keep asking what matters.